when they make recommendations regarding vitamin D. I published a paper a couple of years ago comparing evidence from observational studies and randomized controlled trials for non-skeletal health effects. And it's almost a difference between night and day. So now let's get into the various diseases. I cut my teeth on cancer and vitamin D. So the ecological studies, observational, RCTs, and the mechanisms. Here is the some of the data I used in a paper I published in 2002. So when the Atlas of Cancer Mortality Rate was published in 1999 by the National Institute of Cancer, they showed mortality rates by state economic areas for about 30 types of cancer. And what you see here is they have a color scale from high values are red, mortality rates are red, low values are in blue. For colorectal cancer, it went from about 10 in blue to almost 30 in the red. And you notice that the red is in the northeastern quadrant of the United States, blue is in the south and the west. Now, on the left, you see solar UVB for July 1992. This is from the NASA satellite instrument called Total Ozone Mapping Spectrometer. It's the cloud-free distribution of solar UVB at the surface. It turns out that they called it DNA spectral exposure because the UVB also affects the can affect DNA. I don't think it corrects for aerosols either. So there are three things that affect this and make it asymmetrical. In the western half of the United States, the surface elevation is generally much higher because of all the mountains and just the high desert and so on. So with less atmosphere to penetrate, there's more UVB, less scattering by the atmosphere. Then as the prevailing winds are from the west, and so the air mass has to cross the Rocky Mountains. And in doing so, it pushes up the tropopause and compresses the stratosphere. So we have a thinner stratosphere, and it's a stratospheric ozone that reduces the UVB coming through the Earth's surface. And then you have a latitudinal effect because there's more UVB near the equator than higher latitudes. Now, in the eastern United States, it's all pretty much flat land, and so then you have just the latitudinal effect. So this asymmetry really allows you to say whether it's UVA or UVB. If you go to Australia, you have the latitudinal effect, but you don't have you can't distinguish between UVA and UVB. So it turns out, so it was Cedric and Frank Garland who first identified the role of UVB in reducing the risk of colon cancer. They had maps from 1974 from the National Cancer Institute, which had only 5 colors, and colon cancer was the only cancer that had a really large variation. And see, they grew up in San Diego and had just driven across country to Annapolis to enroll in Johns Hopkins School of Public Health. And when they saw this in their first week of studies, and they recalled that it's very sunny in the southwest, and not very sunny in northeast. And so they realized it was sun exposure. They knew that the most important physiological effect of UV exposure is vitamin D production. So they said, aha, it's got to be that vitamin D reduced risk of colon cancer. It took them 6 years to get their findings published. And then it was in the British journal, International Journal of Epidemiology. The mainstream American journals did not want to publish this. It was just did not believe it, did not understand it. So they went on to show that ovarian cancer and breast cancer were also linked to low UVB, but didn't get much traction. So when this was published in 1999, and I worked at NASA Langley Research Center at the time, I knew about getting the NASA data, and so I could compare the solar UVB doses for each one of these state economic areas for every cancer. And I spent a couple of years doing that. Here's the breast cancer map. And you see this is pretty much similar to one for colon cancer, except now along the West Coast, you have a little bit more cancer, especially along the coast. Well, it turns out along the coast, you have a lot of clouds, especially in the Bay Area. Mark Twain famously said that the coldest winter he ever spent was a summer in San Francisco, because the Central Valley brings in the marine air through the Golden Gate, and we have fog and clouds all summer. So breast cancer may be a little bit less sensitive to UVB and vitamin D than is colon cancer. Now, melanoma, yes, is stronger in the south than in the north, but it's not so much related to UVB. As I said, it's more related to UVA. But the highest mortality rate here is around 4 per 100,000 per year. And you go back here for breast cancer, it's 30 per 100,000 per year. So it's a small amount. Now, my ecological study was for Caucasian Americans from two periods, 1950 to 69, 1970, 1994. And the first study I did in 2002 was state average. The second one was state economic area average. The second one was state average in order to get the other confounding factors such as alcohol consumption, Hispanic heritage, lung cancer, poverty, and degree of urbanization. And it turns out that the effect of UVB was not changed by adding all these other factors. They just sort of perturbations along the general finding from UVB. But while the first study stimulated much additional research, the critics were not going to accept it without showing that the confounding factors had been accounted for. So it turns out that 15 types of cancer were found inversely associated with UVB. There were also 9 associated with alcohol consumption, 6 with Hispanic heritage, 10 with smoking, 7 with urban residents, and 8 with poverty. It turns out that smoking is also an index for diet, which I didn't know at the time. Now, however, it turns out that we have many different factors affecting cancer risk. So in the earlier periods, people in the U.S. spent a fair amount of time in the sun, but they gradually increased sun protection and reduced sun exposure in the second period. They were not obese, and cancer treatment was not advanced, so cancer mortality rates correlated well with cancer incidence rates. Thus, the UVB vitamin D effect was really apparent in the cancer mortality rate data. More recently, Americans have lower unprotected sun exposure. They wear sunscreen. They often stay out of doors. They're staying indoors, working on the internet, etc. They're more likely to be obese and to have diabetes, all of which affect cancer rates. So here is the new maps for, this is the rate of new cancer in the United States, 2016 to 2020. This is colon and rectum combined, all ages for whites, non-Hispanics, males. And you see now, you still have higher rates in the north, but not in the north, so much the northeast. You have the strongest rates in the South, Texas, Louisiana, Georgia. This is due to the diet, obesity, smoking, and probably air pollution. And I'm working on a manuscript to explain this in more detail. Here's female breast. You see here that you still have some effect in the Northeast, but you have a lot also Northwest and in Texas. I think mammography is much more common now. So women are tested every year or two. And of course, obesity plays a role. On the other hand, corpus and uterus cancer still shows a strong UVB vitamin D relationship. Now let's turn to observational studies based on vitamin D supplementation. This is a paper from 2018. It's analyzing results for women who were either in one of two randomized controlled trials conducted by Joan Lappy et al. at University in Nebraska, Creighton University in Nebraska, or it was related to women enrolled as volunteers in the Grassroots Health volunteer cohort who would take whatever vitamin D dose they wanted to and have vitamin D levels measured every 6 months with a mail-in blood spot test. And so what you see here is that on the horizontal, we have concentrations out to about 80 nanograms per milliliter. And we have the frequency of cancer according to the fraction of participants who develop breast cancer in that the different concentration range. And you see it's almost a straight line decrease from one place to the other, from low to high. And so it's shown here that there's an 82% lower rate for those who had greater than 60 nanograms per milliliter compared to less than 20 nanograms per milliliter. Now, there are other factors involved. For example, those with the higher concentrations had a lower BMI, more like 24, 25, than those in the Nebraska studies who had a BMI more like 30. So BMI does also affects concentration. But you want to look here at the, say, going from 30 to 40 nanograms in the middle. It turns out that if you use only 2,000, the Nebraska study used 1,000 IU per day plus calcium. The VITAL study I'll discuss later used 2,000 IU per day. And so if you're going to use only 1,000 or 2,000 IU per day, you're only going to move from maybe 30 to 40 nanograms per milliliter. So if you measure just on the basis of were they treated with vitamin D, you're only going to get the effect of 10 nanograms per milliliter, which is not going to show very much. You really got to look at a large range of 25-hydroxyvitamin D to find a good effect on cancer. Now, it turns out another consideration in observational studies is that the longer the follow-up time, the lower the observed effect. In other words, what I'm trying to say is that, well, 25-hydroxyvitamin D changes as a function of time. So does diet. So if you enroll people, say 12, and then follow for 12 years, you're not going to find much of an effect of vitamin D. And so what I've done is I've plotted the observed effect for high versus low 25-hydroxyvitamin D for men and for women, men in the dots, women in the circles. And I show that if you extrapolate to 0 follow-up, you'd find about a 23, 24%, 25% reduction in colorectal cancer. So when the paper was published using the non-thinking way of put the data in and turn the crank, they did not find an effect of vitamin D, or found a very small effect. But this shows that there was a large effect if you consider follow-up time. So now we turn to the VITAL study. This was run by Joanne Manson at Harvard University. It enrolled over 25,000 participants, including over 5,000 African Americans. Half received 2,000 IU a day vitamin D3 and half a placebo for 5.3 years. There is also an omega-3 fatty acid study, which was different from this. So we say that half of these who received vitamin D also received omega-3 and half did not, but that did not affect the vitamin D study. The mean baseline 25-hydroxyvitamin D for those providing vitamin values who were treated with vitamin D is around 31 nanograms per milliliter. So that's even above the average 25-hydroxyvitamin D in summer for the United States. And all participants were permitted to take up to 600 or 800 IU per day, as well as spend time in the sun and eat whatever they wanted to. So you did not have a good control group. It turns out that those who did not take vitamin D, those who took vitamin D had about a 12 nanogram per milliliter increase in vitamin D. So what did they find? For the entire group, there was about a 25% reduction in all cancer mortality rate, but no significant effect on cancer incidence. Well, it turns out that vitamin D is more effective in reducing cancer mortality rate than it is in reducing cancer incidence. The simple way of thinking about that is that there are many factors that result in cancer. You have the effects of DNA damage by smoking, by alcohol, by pesticides, et cetera, et cetera. But when it comes to progression of cancer, you've got to have blood vessels grow around the tumor in order to bring nutrients to the tumor. And vitamin D reduces angiogenesis around tumors. It's one of the few things that does that. And then vitamin D also reduces metastasis into the surrounding tissues. Again, one of the few things that does that. So it's not surprising that mortality rate was affected stronger than incidence. Now, on the other hand, for those with body mass index less than 25 kilograms per meter squared, there was a significant 25% reduction in cancer incidence, but not for those with 27 higher than 25. For African Americans, there was a barely non-significant 25% reduction in cancer incidence. And that's because African Americans had lower mean 25-hydroxyvitamin D than the white Americans. Now, the abstract, which is what most physicians read, did not mention these beneficial effects. The study was published in the New England Journal of Medicine, and that's primarily an advertising tool of big pharma, and they have the rule that there can be only one outcome per study. And so they did not want to let the physicians know that there were some other benefits. If you looked under the hood, you would find them, but most physicians don't have time to look under the hood. And in all the press conferences, Joanne Manson didn't bother to mention these other benefits. Now, here's what they showed in terms of BMI, a 24% reduction for less than 25, no reduction for higher values. Again, it was about a 12 nanogram per milliliter increase in 25-hydroxyvitamin D. Now, here's a very interesting study that just came out about a year ago. So the P53 gene is a tumor suppressor gene, and its activity stops the formation of tumors. They did a study where they were looking at patients with digestive tract cancers, and they did a 5-year study on relapse or death. And they looked at a subgroup of patients who were P53 immunoreactive, That's defined as positivity for anti-P53 antibodies in serum or nuclear accumulation of P53 oncosuppressor protein in more than 99% of the cancer cells. So some of these patients had lost the use of their P53 gene. And the results are, if you look at on the left, you see that for those with the, these is those without the P53 gene working, those given the placebo almost all died, or we call that, with the placebo, they have very poor outcomes. Those with vitamin D had only about a 20% relapse. And if you look at those without the P3 effect on the right, vitamin D didn't have any effect. So what this is about, finding about a 16% reduction in mortality rate due to vitamin D supplementation and having the P53 effect being deleted, not working. So this is done for digestive tract cancers, but as far as I can tell, this would affect all types of cancer. And so this means if you get cancer, you probably want to have your oncologist find out, are you P53 immunoreactive or not? And if you don't have your P53 working, be sure that you supplement with high-dose vitamin D. The mechanisms, I've already discussed this. Well, the first thing is that vitamin D reduces cancer incidence by mechanisms such as surveilling cells and allowing good ones to differentiate and proliferate and build the organ, but causes cancer-forming cells to disintegrate through a process called apoptosis. Now, moving on to infectious diseases,